Okay, but before we dive headfirst into all the exciting new stuff, let's pump the brakes for just a second. We need to talk about what isn't changing, because some things are still the absolute bedrock of good sepsis care, and we can't forget them.
Look, no matter how sophisticated our strategies get, these three things, they are totally non-negotiable. Early recognition, early antibiotics, and early resuscitation. Think of them as the three pillars. They're just as critical today as they've ever been.
All right, so let's rewind and look at that rule book we mentioned. I'm talking about the 2021 Surviving Sepsis Campaign Guidelines. And, they gave us this really necessary standardized approach. It was designed for one thing: rapid, decisive action to save lives. Speed and consistency, that was the name of the game.
And the rule book was super prescriptive, right? It was like a checklist. Start antibiotics within an hour. Give that standard 30 milliliters per kilogram fluid bolus. Use vasopressors to get the mean arterial pressure, the MAP, up to at least 65. And oh yeah, think about steroids if the shock just isn't responding. The rules were crystal clear, all built for speed.
And this is the turning point. It kind of makes you wonder, right? If the rule book was so good at saving lives, why on earth are we changing it now? What new evidence is pushing this massive shift in how we think?
And that's a totally fair question. Why mess with a protocol that has, without a doubt, saved countless lives? Well, the answer really boils down to unintended consequences. And, of course, this growing mountain of evidence that's telling us, hey, we can do even better.
So here's the why. It turns out, when you apply those rigid rules to everyone, you run into problems. We started seeing concerns about overdiagnosing sepsis, which in turn fueled antibiotic resistance. And then there was the real risk of hurting some patients with too much fluid. Yeah, we learned the hard way that one size really truly does not fit all.
And that's what leads us to this new playbook. Now, let's be clear. This isn't about tossing the old rules in the trash. Not at all. It's about applying them way more intelligently. It's a patient-first strategy where our decisions are guided by what the patient's body is actually doing, not just by what the clock says.
Okay, so let's break down the first play from this new playbook, antibiotics. The old rule was simple, right? Get them in within an hour, period. No questions asked. The new approach? It's still urgent, don't get me wrong. But, and this is a big but, it allows for a crucial pause, a moment to evaluate, especially when the diagnosis isn't a slam dunk.
And the whole reason for this change? It's all about better antibiotic stewardship. That thoughtful pause gives a clinician time to ask, wait a minute, could this be something else? Could this be a massive PE or acute pancreatitis? By just taking that moment when things are a little muddy, we can hopefully cut down on overdiagnosis and help fight back against antibiotic resistance.
All right, next up, fluids. And guys, this one is a huge deal. The old protocol was that standard 30 milliliters per kilo bolus for everybody who walked in the door. The new thinking is completely different. It's all about an individualized, dynamic strategy. We are totally abandoning that one-dose-fits-all model.
So, you're probably asking, how do you tailor fluids? Well, we do it by using dynamic assessments. We can do something like a passive leg raise, which is cool. It's like giving the patient a fluid bolus of their own blood, and we watch to see if their numbers improve. Or we can use really simple but powerful tools right at the bedside, like checking capillary refill time. The whole goal is to figure out who the fluid responders are, the people who will actually benefit from more fluid, and just as importantly, avoid giving it to those who won't.
And you can probably guess what's next. The same idea applies to blood pressure. The old rule, a MAP of 65 for every single person. The new trend, you guessed it, personalize that MAP target based on the actual patient in front of you.
So what does that look like in the real world? Well, think about an elderly patient who has chronic high blood pressure. Their brain is used to a higher pressure just to function normally. For them, a MAP of 65 might actually be too low, so we might aim for a higher target. The real focus is shifting away from just one magic number and towards the real goal, making sure the tissues are getting enough oxygen. And we can track that with things like, capillary refill and lactate clearance.
And that leads us right into monitoring. Look, lactate is still a huge deal, a real cornerstone, but we're realizing we can't only look at lactate. The new playbook is all about combining that lab value with powerful, simple bedside tools like capillary refill time to get a much more complete, real-time picture of what's happening with perfusion. But believe it or not, this evolution doesn't just stop after the first few critical hours. The new playbook is expanding, and it's pushing us into the next frontier of sepsis care, which is all about what happens after that initial crisis is over.
You know, for years, our focus as clinicians was laser-focused on that acute management phase, getting them through the first day. Now the emphasis is shifting, and it's shifting hard towards post-sepsis care. And the ultimate goal down the road? True precision medicine.
And this is just so incredibly important. We're finally, as a community, recognizing that surviving sepsis is just the first battle. The war isn't over. There's this new strong focus on what comes next, managing all the long-term consequences, everything from physical rehab to the cognitive problems, that brain fog, that we often call post-sepsis syndrome.
Okay, so let's put this all together. As you can see, pretty much every single piece of sepsis care is shifting. We're going from rigid timelines to thoughtful evaluation, from fixed doses of fluid to dynamic assessments, from one-size-fits-all targets to personalized goals. The whole approach is just becoming smarter, more nuanced, and way more focused on the individual.
Honestly, if you only remember one thing from this whole explainer, let it be this. The fundamental shift is from a rigid protocol to personalized, physiology-based care.